Well, hello, everybody. We'll first give our attendees just a moment to join us. And I am Lauren Source, and I would like to welcome you all to Taking Stock of Pediatric ICU, Pediatric, and Neonatal Nursing, session number 2. We have a wonderful panel here today to answer some important questions about nursing in our field. And I will start with introducing our panel. Laurie Lee from Canada is a pediatric nurse practitioner and in the pediatric intensive care unit at Alberta Children's Hospital in Calgary, Canada. Courtney Nerovich is a clinical nurse in the Lefkowski Family Pediatric Intensive Care Unit and a founding member of the Nursing Ethics Forum at Lurie Children's in Chicago, Illinois. Chris Ann Rodriguez is from Guyana. She's a registered nurse, pediatric surgical and pediatric critical care unit at the Georgetown Public Hospital Corporation in Georgetown, Guyana. Maria Paula Oliveira Pires is from Brazil. She's a lecturer in nursing at the Paulista University, Sao Paulo, Brazil. Ursula Goransky is from Italy, where she is a healthcare professional in the developmental unit in the Bambino Gesù Children's Hospital in Rome. Levon Toom is in the UK. She's a reader in child health, critical care nursing, School of Health and Society at the University of Salford, Manchester in the UK. Next up, we have Fenella Gill, who's in Australia. She's an associate professor, acute pediatric nursing at the School of Nursing, Midwifery and Paramedicine at Curtin University and Perth Children's Hospital in Perth, Australia. Poh Pei Fen is from Singapore, where she is an assistant nurse clinician and ECMO nurse specialist in the Division of Nursing, KK Women and Children's Hospital in Singapore. Manjinder Kaur is from India. She's an infection control nursing officer, postgraduate Institute of Medical Education and Research in India. Mavilde Pedrada is from Brazil, where she is the Dean of Pediatric Nursing, Paulista School of Nursing at the University Federal del Sao Paulo in Brazil. Marisa Singhi, also from Guyana, is a nurse manager, pediatric surgical and pediatric critical care unit at Georgetown. And Minette Coetzee from South Africa, who leads the Harry Crossley Children's Nursing Development Unit, Department of Pediatrics and Child Health, University of Cape Town, South Africa. Muse Makwatsi is also from South Africa, where he's the operations manager for surgery at the Nelson Mandela Children's Hospital in Johannesburg, South Africa. I would like to welcome you all to our conversation today. So we are going to start by talking about the first question. What is the impact of burnout in your professional community? And we'll start with the North American perspective with Laurie Lee.
Thanks so much, Lauren. And thanks again for inviting me to be part of this panel. It's a real honor to be here with so many distinguished nursing leaders from around the world. I think, nursing burnout is definitely an issue facing nursing ubiquitously across nursing as a profession. Coming forward and currently, there are unique situations for pediatric and pediatric critical care nursing, I think, as well. There's a beautiful scoping review published last year, published this year, actually, specifically looking at burnout in pediatric nurses. And that was published by Buckley. And that group looked at PICU as well as general peds nursing burnout, and that lots of themes emerged, but certainly one that resonated with me is finding the balance with professional engagement and professional satisfaction as a mitigating factor for burnout. We know that working in pediatric critical care comes with a really high number of risk factors, specifically the exposure to sadness, trauma, and literature in and out of nursing shows that when you have pediatric traumatic events, that increases your risks of PTSD, long-term psychological effects, and burnout. And in nursing, it seems to be even more exaggerated than some other healthcare professionals. And there's lots of theories about that. Some is the length of exposure. So we know, especially in bedside nurses, the exposure throughout the entire shift to the trauma, where a lot of other professionals are able to come and go from the bedside throughout the day, increases their risk of burnout. And we can't really change these factors. This is who our patient population is. We all chose to work with these children and their families, and know that dealing with the trauma, death, dying, and sadness that comes with it is part of the profession. And so I think what's really interesting is looking at this professional satisfaction and professional competence as a mitigating factor, and how do we build on that in pediatric critical care nursing to create environments that allow our nurses to thrive and have that professional satisfaction in order to mitigate the burnout that we expect to be present. Some other things that have been highlighted in the literature are that, having supports at the bedside and in the unit are really important. And one thing that has been more prevalent and on the rise in Canada is the establishment of peer-based critical incident stress management teams. And those have been shown in early literature and certainly anecdotally to be really helpful in providing just-in-time management for dealing with trauma on a peer support basis that really helps support our staff in dealing with the trauma that they see at the bedside, so that they can come back to work wholeheartedly to be able to be there for their families. I think another important thing to remember that's also been highlighted in the literature is that nurse burnout is associated with a worse safety climate in ICUs. And so we need to make sure we're framing nursing burnout, not just from the standpoint of we don't want our nurses to burn out because we're human, but also because it actually negatively affects patient care. And so this needs to be a priority that we advocate for at an administrative level, that we have interventions to target reducing nurse burnout as a patient care intervention, which I think is really also very important. And then when we talk about the nursing professional engagement, is making sure that we provide a working environment that allows our nurses to be the best professionals they can be, to give them the most opportunity to feel proud of their work and help balance whatever trauma they suffer. And then finally, the last little piece I want to talk about, which I think maybe more of a North American sort of Western European, Australian perspective, but I would love to hear if this is something people face globally, is the increasing rate of complex, chronic, mechanically dependent children that are occupying our ICUs. So the population in Canadian PICU certainly has changed over the last decade, where we aren't limiting goals of care on children nearly as much as we used to, and we have our children that are living in our ICUs. And this dilemma that our bedside teams face with the appropriateness of providing ongoing care, I think is the future of burnout for pediatric ICU nursing. And I suspect will require different interventions. Thanks so much.
Thanks, Laurie. Courtney, same question. What's the impact of burnout in your professional community?
I think burnout is a huge problem, especially in our unit. So we're a 40-bed PICU, and in 2017, I actually did a study on burnout in our unit, and my goal at the end of the study was to not only just focus on the burnout, but how do we fix the problem and more work towards resiliency in our nurses? So something that I felt was very important was to discuss these types of events that we are involved in as bedside nurses. As a charge nurse, I had been exposed to several traumatic events, and we're also the code team at Lurie Children's. So I would respond to a code on the general floor, and then be expected to come back and run a 40-bed unit, be in charge of staffing, helping other nurses, and helping never really able to digest what just happened. And something that came out that that I got from the study was that the nurses just really wanted to talk about what happened. We can't just be expected to see these traumatic events, code patients, talk to the families, be exposed to this, and then just continue on our day. So something that I implemented and that I created with one of our other providers at work was a tool called the Rapid Review of Resuscitation. And it was a guideline that anyone that was involved in a patient code, we would sit down, get together that day during the shift just to discuss the events of what happened. The goal was to provide a very safe environment for anybody to come, all the way from nursing to our nursing assistants to pharmacy techs to our secretaries, getting just everybody in the same room just to discuss the event and allow anybody to ask questions. And I feel like from a bedside nurse, just going through the process and asking, how did this happen? How did we get here? Did we miss something? Could we have done better? What did we do that worked really well as a team? And what did we do that, could use some, that we could work better on in the future? And I think it was just really important for us as bedside nurses, instead of taking all of that and going home and then sitting on your couch and analyzing the event, because that obviously leads to burnout, is just talking about it at work, getting our questions answered, and then allowing us to kind of leave it there. And another thing that I thought was really important too was, we see death all the time. And not only do we need to recognize the child for, having to go through that, but also recognize the work that the healthcare providers put in to trying to save that child. So giving ourselves a moment just to sit in a moment of silence and to recognize the work that we all provided and that we all do on the unit every day. I think that really, really goes a long way, just to recognize again the nurses and the hard work that we do, and telling people that this is not an easy job, this is not normal, and let's give ourselves a safe place to talk about it. And I studied it over several years, and the nursing staff, the physicians, everybody just really, really seemed to enjoy it. And now it's actually, it's something that we use house-wide. So it's something, that the emergency department uses, that the cardiac ICU uses. So I think, we all are aware that burnout is, it's very pertinent in our units, but let's not just recognize that and say that it's a problem, but let's figure out the solutions and find a way to help the nurses deal with that burnout. So that was something that I took amongst myself. And I think that it was really beneficial to our staff and to the hospital in general. So.
Thank you, Courtney. We're going to move over to the Caribbean, and Chrisanne, same question. What is the impact of burnout in your professional community?
So, So like any other healthcare setting across the globe, burnout continues to be one of the major issues facing nurses in Guyana. Unfortunately, we do not have systems in place to deal with the issues that the nurses are facing. So unfortunately, they become so emotionally overwhelmed to the point where not only does it affect their work life, but also their personal life. We have nurses taking that stress from work into their home settings. In the workplace, what we usually see are changes in nurses' attitudes, which makes it difficult for them to communicate effectively with other members of the healthcare team. So there is an issue there where we have increasing interpersonal conflicts on the floor. We have decreased productivity as nurses are overworked and too overwhelmed to provide the care that they should be providing to patients. We have seen increase in sick days, absenteeism, unpunctuality. Nurses become less motivated to learn and display a lack of interest in developing new skills. We see nurses beginning to question their decision to actually become nurses. And I think the biggest impact that we see is that persons eventually quit and join other field of work. And we have others who would eventually leave for greener pastures. So the whole brain drain situation comes into place, eventually.
Thank you, Chrisanne. That was excellent. We're going to move over to Maria in Latin America with the same question about burnout in your professional community.
Yeah, thank you, Larry. Hello, everyone. I'm a professor at Paulista University in Brazil. I'm very happy to be part of this event. I would like to thank you, the organizer, for the invitation. And the burnout has been more discussed in Latin America because there has been an increase in the number of cases, which may result from new working conditions or new individual expectations, or just an increase in reports or data. We have many barriers in our country, so many strategies that are already known to promote mental health at work and prevent burnout are not implemented due to a fragile system caused by political, economic, cultural, organizational, and other factors, sorry. So to reflect a little, I would like to bring some data from Brazil, in which some of these Professor Carvalho discussed it wonderfully in his presentation at Congress. We have a role in the ICU that must have one nurse to take care of 10 patients and one nurse technicians for 2 patients, regardless of the complexity of the care. And some hospitals don't follow even that minimal number. Another important point is the work overload and the low salaries of professionals, especially newly graduate nurse or resident physicians. They earn an average of $4 per hour. Therefore, many professionals need to work in 2 or 3 jobs, and for sure it generates enormous fatigue. We still have a vertical relationship and interpersonal conflicts in the workplace. A pandemic survey of 13,000 nursing professionals in the state of São Paulo found that 87% said they had symptoms of burnout, and only 14% undergo psychological treatment. It is clear that many professionals are having to fight burnout alone, and this number shows the patient safety is affected. At the organizational level, I don't believe that we are taking good care of our health professionals, even in the pandemic, that they receive so much attention. We need to rethink how to create and maintain healthy work environment, reduce workload and time, limit continuous working days, providing training and resources to build resilience to deal with the stressful work, encourage cognitive behavioral therapy, establish support group, and train professionals to seek individuals' ways to reduce the stress level of stress. Some studies bring the individual responsibility for take care, but we know that it's not easy. However, some habits and practices can help, and we can support them, such as good relationship, yoga, mindfulness, meditation, close family, healthy eating, physical exercise, good sleep, spirituality, and others. It is also important to know yourself and to know who you are and your purpose in order to be able to give enough energy for daily work within PICU. To end, I'd like to bring here what Professor Cinda said brilliantly, that when you reflect on these aspects of your purpose, you stop being distracted by external issues or negative thoughts or the past or the future, and you focus on what you are doing here and now in the present. And with that, added to a support team and strong system, you do a good job, the patients will be safe, and you will probably be happier. So that's it. We need to do more. Thank you.
Thank you all. And for the participants, Levon made a posting. Levon, do you want to take about 1 minute to say what you put in the posting?
Yeah, thank you, Lauren. So, I mean, one of the issues certainly in the UK has been that if there is any conflict with the teams here, and because of these these have been typically chronically ill patients, long-term complex, where there was disputes between what the parents wanted and what the team wanted. And the parents have taken to social media quite actively and quite aggressively in a way that's been really harmful for the staff, both nurses and the rest of the team. Actually, when I say harmful, I mean, actually attacking our staff, Facebook and Twitter profiles and stuff as well. So really quite harmful for these patients psychologically, for these staff psychologically. This has certainly made a big impact. There were 2 cases 2 years ago that went to the High Court here. So it's been an issue for us in the UK.
Thank you, Levon. I appreciate you contributing that. I think that's a problem in a variety of places, not just in the UK. We are going to move over to our next question. And we first...
Lauren, sorry.
Yes, Anne?
I think I had the Europe region in this burnout section.
Oh, so sorry. Please go ahead.
No, that's okay. I slipped into the program quite late, so maybe you haven't been updated. That's okay.
It's excellent. I'm happy to have you here and comment on it.
I will be quick. I mean, in Europe, I think like we are experiencing the same problem as everybody has cited. What I would like maybe to add to the debate and the conversation we have today is COVID actually accentuated the whole burnout problematic. And, we had problems of burnout. I think it's up to 20% in our hospitals, actually, and including, the pediatric wards. And it's probably underestimated because there's a very interesting new review on burnout by Peter Griffith and colleagues that has been published recently this year that shows that the questionnaires that are commonly used for measuring burnout in nursing doesn't take into account all the dimensions of burnout. And so the figures we have are probably underestimated. And with the COVID situation, the figures actually are going right up. And the reason for this is basically, like excessive workload, professional conditions where you are not necessarily in control because of the emergency. And what is happening in Europe a lot is that because we don't have a lot of COVID patients, pediatric patients, the pediatric nursing staff has been shifted to help in adult ICU, and that caused a lot of distress. And we haven't got really any official report of the consequences of that, but my guess is that it's not going to be very good. What we experienced during the first wave of COVID is that people were very happy to go and help because there was like this, this feel of emergency and duty of care that was really strong. And now with the second wave in Europe, where we have a lot of difficulty to actually coming out of this second wave, and we are already predicting the third wave end of January, people are so tired. They are very tired. And I mean, fatigue and physical and mental fatigue is a high risk of developing burnout as well. So yeah, I just wanted to share this with you.
Thank you, Anne Sylvie. I think that each one of the geographies that have presented have talked about really important points in burnout. And all of these points, I think, are pervasive in all areas of the world, even though each geography has something that's a little bit unique to it. So thank you all for bringing your perspectives to the table. Okay, I believe now we're ready for question number 2. And this question, number 2, is going to focus on high income countries, and then we'll have the same question for low and middle income countries. So the question is, if you could share the 3 most pertinent topics impacting pediatric critical care nursing in your region, what would they be? So Ursula, we're going to start with you. If you're talking, Ursula, we can't hear you.
Can you hear me now?
Yes, we can.
Great, thank you. Okay, so thank you, Lauren. So with Livon, we sent a very brief survey to our colleagues across Europe to get a more consistent picture of what were the most important topics and issues that are being dealt in European PICUs. And what we found is that stress and burnout is the first. The second is staffing. And the third is low pay. So stress and burnout at this point in time, particularly, as Anne-Sylvie pointed out, is really a very hot topic. And I believe that across Europe, there is really an extreme variety in terms of strategies and interventions that are put in place. And I'm pretty sure that in many countries, there isn't even the opportunity to work on these issues because of many reasons. Staffing is the other hot issue in Europe. Staffing levels also are quite variable across Europe. And so, for example, in the UK, you have a 1-to-1 patient ratio, but in other areas of Europe, including my country, for example, there is an average nurse-patient ratio of 3.5 patients per nurse, which is very high. And I believe that in other countries is even worse. So there is an extreme variability, and this brings unsatisfaction in nurses and all sorts of issues, such as wanting to leave the profession, and unsatisfaction and burnout. And for example, the Iran forecast study in Europe showed, for example, how nurses in PICU, after 10 years of work, the majority of those nurses, so a very high proportion, less than 50%, but still very high, expressed the desire to leave the profession, to leave nursing. And this is very worrying, because this means that there is really lots of work to do to retain nurses and to make the profession more, more, now the word doesn't come to me, but like satisfying for nurses. And another important issue that I would like to raise is the lack of professional development. In most European countries, but let's say more than 50%, you don't have the possibility of developing in an advanced practice role. The only way to grow professionally in your career is become a nurse manager. And this is not satisfying, is not responding to most nurses who would like to instead have other opportunities in their career. And the reasons for this are manifold. So there are reasons that have to do with finances, with budgets that hospitals have and don't want to increase and have new nursing roles, but there are also issues that have to do with competing interests with medical associations and other reasons. So this is another aspect that really needs to be looked at and worked on. And Livon, would you like to say something? Otherwise, I'll keep going.
I mean, I agree with all.
Yeah.
We did
Yeah.
this survey. There are a few other issues. I mean, I think, remember, there are 51 independent states in Europe. So, you know, it's really the variety is even more diverse probably than other places. And so although we got responses from 11 countries, and I've worked on units in 4 countries, you know, but still there's great variety. But as Ursula said, the top 3 are, you know, stress, poor salary, poor staffing levels, lack of recognition of ICU nursing as well in many countries as an entity, and the lack of recognition of ICU nurses as being any different from anybody else. You know, the example for this is in France recently, and there's been a great critical commentary written on this by the French nurses that, you know, it's only September this year that critical care nursing in France was recognized as an entity. So they didn't have a professional society of critical care nurses, and they're lumping neonatal, pediatric and adult all together, but maybe that's where they have to start, until September this year. It's really by COVID that this happened. So, you know, if you don't have this, then there's no national curriculum. Many of the countries, even before you get to advanced practice, like Ursula said, when we surveyed in ESMEC a couple of years ago, very few of the European countries actually have a specialist intensive care nursing course for children. So very few. Some of them, they did a generic critical care course, which was really adult. You know, the Scandinavian countries, that's the model they have. Italy, I think Ursula, you said as well. The UK and the Netherlands, and I think Switzerland and Sylvie can add it, have a specialist course for children, but the others have nothing. So, you know, education and development and lack of career progression, like Ursula said, was another issue. Some nurses wanted to do research, but there was no resource to do it. That was highlighted. And in terms of, so all the things we asked them, very few clinical issues got raised, but when they did, they were independent things. But the one thing that did come through, which is what I think Laurie said, is that, you know, there was this changing profile of complex patients that stayed a long time, very complex, often almost would be considered, actually many years ago when I started in ICU, they would have not come to the ICU, okay, you know, but now of course they're very complex, we try and manage them, but often the outcome is not good and they stay there for a long time and there's conflict with the family, which leads to the other thing. But that was highlighted as an issue. And probably in terms of more developed European countries, things like early mobilization, delirium scoring, these sort of things. But remember, there's such a huge diversity. If you haven't even got nurses that have an ICU course or don't have a degree as a baseline level, and some countries don't and some countries do, you know, and also they're looking after 6 or 7 ventilated patients, you know, how can I expect them to think of other things, you know? So it's really diverse in Europe, I think.
Thank you, both Ursula and Levon. That was excellent. We're going to move over to Fenella. Same question.
Okay, thank you. Thanks, and great to see everybody again this evening, I'll say. I guess similarly did reach out to colleagues in other states, in Australia and in New Zealand. So I've got a little bit of a state-by-state perspective, but there's a lot of similarities from what others have said. And then I was hopefully, if I've got time, just talk a little bit about from a research reporting output perspective about what have been the top topics for pediatric critical care nurses. So in Australia in particular, it's the state of Victoria where COVID has been a big issue, and that's been pretty much the only state that's really been so greatly affected by COVID, and that's reflected then in what nurses have told me that has been the concerns or the issues, topics affecting pediatric critical care nursing. Fears of increased infections to staff is a concern, and the changing of their practice, the impact on family visiting, restricting it to only one parent at the bedside has been a massive impact, and then also on the impact on nurses, that education is all now online, if any education is available at all. So they've really recognized that moving on to 2021, that well-being and the psychological impact is going to be a big factor. Then in New South Wales, less mention of the impact of COVID, but the diversity of the critical care nurse workforce and professional development opportunities. So trying to be creative to create a opportunity for career development. And then at the beginning level, the ability to have that transition program into critical care that is very resource intensive and expensive, but so key that that's something that's always under review. When I had a bit of feedback from New Zealand, there was some mention of the change in practice of COVID, because the changing demographic of patients who were now populating the ICU back, certainly in the last few months, less respiratory admissions, no bronchiolitis, for example, and then no ability to provide the outreach programs that those nurses were, a number of them were involved in, such as cardiac surgery programs out to other regions in the Pacific, that they were not able to provide those any at that time. In Western Australia, the message has very much been about staff well-being, supporting staff, burnout, compassion fatigue, so the things that others have talked about, work-life balance and health and well-being. And then that was also reflected then from Queensland, work-life balance, health and well-being, compassion fatigue, moral distress, so exactly the same top points that are being reflected. And so then just with the journal editor hat on, because as you know, I'm the paediatric editor for Australian critical care. If you look back in the top 5 years in critical care nursing overall, and that also includes paediatric critical care, then end of life care is the top topic for the last 5 years. That's been research outputs, followed by sedation, delirium, sleep, enteral feeding, resuscitation, workload, communication, and then down to respiratory care with suctioning. And then on that list, there was then burnout. So it'd be interesting to see over the next few years whether that sort of ranking of outputs does change. And then if I can just indulge you just for a minute, the 2019 best paper from Australian critical care was a paediatric critical care paper from Rodriguez, Ray and colleagues in Spain, and that was burnout and post-traumatic stress in paediatric critical care staff in Spain. And so I guess that's really quite on point, even though that was a paper that was submitted in 2018, but it was a multi-center survey of 9 hospitals of doctors, nurses and nursing assistants, and they used the brief resilience scale, coping strategies questionnaire, the Maslach burnout inventory and the trauma screening questionnaire. And collectively they found that over half of the PICU workforce reported burnout on at least one of those dimensions. And the conclusions were that that the interventions are needed, of course, and I guess we can all agree on that. But the actively processing and managing stress and having positive thinking, and so interventions to promote that are going to be key. And I guess just the other thing I meant to say was the most traumatic events were death of a child and conflicts with patients and families. So I'm happy to share that that paper if I can through the through this forum, because I think that it's very definitely relevant to the discussion. I think that everyone is touching on burnout and stress.
Fenella, that would be great. And I see Levon has piped in as editor of Nursing and Critical Care that the results are essentially the same. So I think Fenella, if you can share that, the link to the paper, and then it could be posted on the WFPICCS website, that would be excellent. So thank you. Okay, we are going to move now to Laurie Lee. Same question.
Yeah, thank you so much. I think as other people have already discussed, I think, you know, the issues facing pediatric critical care nursing really vary globally. In Canada, we have the fortune of having well-paid, highly regulated professions. So our nurse-patient ratios across Canada in a PICU are a maximum of 3:1, and for ventilated patients are 1:1 in most PICUs in most circumstances. So I think that means that the issues facing nurses in our country are going to be different because we have the privilege of having already resolved is probably too strong of a word, but made more headway on really some of those workload issues that obviously will be more prevalent before you're able to move on to some of the other issues. One that I think people have already touched on in really an unofficial discussion with my colleagues across the country is the recognition of pediatric critical care nursing as a specialty. In Canada, for the most part, the nurse is a nurse mentality is quite pervasive. There are adult critical care specialization courses, but not all jurisdictions recognize critical care as a designation. Nursing is highly unionized in Canada, which really contributes to the same salary for everybody, no matter where you work, which is really demotivating for our staff because, as we all know, especially in pediatric critical care, there's a lot of knowledge and skill set that is developed to be a competent nurse. So I think that recognition, both in the professional organizations, so we do have the Canadian Association of Critical Care Nurses to recognize critical care nursing as a separate entity, is wonderful. We're working on a pediatric subgroup, but there isn't a formal one yet within that. But I do think administratively in hospitals, the lack of both salary and just verbal recognition of nursing specialization is a problem across all nursing specializations, but certainly in pediatric critical care. So I echo what other people have said about that. The second sort of major issue is one that I brought up in the burnout conversation, but this moral distress around our long-term chronic complex patients is really identified by nurses across the country as a real problem. And I think Levon spoke about the sort of legalization process that is coming out more and more, and we have more of these cases happening almost on a yearly basis now in most PICUs. And I think that the bedside nurses, in the way our systems work, are kept at arm's length from a lot of these conversations, but yet are the ones expected to be at the bedside caring for these families throughout the entire process. And so what we have heard across our country in conversations with different colleagues is that really starting to involve bedside nurses more in the discussions and in managing these difficult situations, I think, is an important way to support them as they also have to deal with them. And I think how we as a multidisciplinary team manage these challenges that are going to come up more and more in sort of keeping these children alive that as a medical team we may not agree with is a pressing issue. And I think one that we're going to see more and more of as our ability to keep children alive increases. We're going to face these challenges of who and how to do that. And we actually discussed how in a high income country, our plethora of resources has actually created this problem because we are able to do these things for a very long time. And that creates a lot of challenges. And then the last pressing issue that really has come up a lot was comfort and survivorship of our ICU patients. So we do a lot of work on pain, agitation, and delirium, keeping children more awake. And that puts a massive burden on the bedside nurses in ICU. So they carry the load of lighter sedation and maintaining comfort in the ICU. And so making sure that we provide them with the knowledge and the supports to be able to do that work well. And then getting data on what that means for our patients long-term. We've never had that to be able to reassure or not reassure all levels of profession in the PICU about what the long-term effects of our patients are. And our nurses certainly really have expressed that that's a need. And I know I was only supposed to have 3, but I have a 4th one, if that's okay. And the biggest one, not the biggest one, this is one of my biggest pushes, is because of the level of unionization in Canada, very few hospitals, and Sick Kids in Toronto is one of the few that's not unionized. And there's a really big difference that's obvious there. Excuse me, is the big separation between bedside nurses and academia for nursing, where other than going into advanced practice roles or moving into academia, there's a lot of barriers to bedside nurses being able to do research and advance their career while staying at the bedside. And I think that's a really big challenge, that the only career advancement requires nurses to stop doing direct patient care and move into a nurse practitioner role, a CNS, an administrative role. And I think that, you know, our physician colleagues are able to practice clinically and do research and teach and be part of academia. And those pathways aren't present for nurses. I think, you know, we've talked a lot about burnout, and I think increasing job satisfaction is a really good intervention to prevent and manage burnout in our staff. And so I think we need to find ways to make it easier for our nurses to advance their careers and stay at the bedside and look after our patients. And I think, you know, that is a way to retain nurses and maybe mitigate some of the burnout from the trauma that we have to experience, is by getting some professional satisfaction through growing their roles in other ways without having to leave the bedside.
Great, thank you, Laurie. We're going to move over to Courtney now.
Thank you, Lauren. I think I'm going to mimic and echo a lot of what everyone else has already said, just from polling my colleagues, and in general, the main 3 topics, again, are, I think they're all intertwined as well. Burnout resiliency is huge right now, between implementing programs, not only unit-wide, but house-wide, of trying to really build strong, resilient nurses has been big. But also, like everyone else has said, the advancement in medical care has really increased our length of stay for patients in hospital. And I think that's, you know, nationwide and worldwide, that, you know, our long-term patients are on ventilators and requiring a lot more life-sustaining therapies, and our parents able to truly take care of these patients at home, or are they going to stay in the pediatric ICU and then transfer over to a long-term facility? So I think as a bedside nurse taking care of these patients, it makes it pretty difficult, just because, you know, we're day in and day out taking care of them to ultimately go to a long-term facility, which again can be really challenging and lead to burnout as well. And going with that, I think, you know, ethics in nursing has been a huge issue as well. Again, like Laurie said, that the bedside nurses are the ones that are dealing with the biggest problems, you know, all day that we see. And I think we need to look back and kind of assess, is it, you know, quality over quantity of time that, you know, patients and families are having together. And a lot of the issues arise of, we keep doing things and doing things and doing things to children, but to what cost? And are we implementing, like, are we causing more harm versus, you know, is it beneficial to them? So I think as a bedside nurse, it's caused a lot of ethical dilemma when it comes to these life-sustaining therapies that we're you know, giving the children. So just a lot of talk about that, and how can we as bedside nurses be a bigger part of these conversations? Because again, the doctors are the ones that are meeting with the families and coming up with these long-term goals. And as a bedside nurse sitting there and day out having to care for these patients, it's definitely important that nursing needs to have a voice, and nursing needs to be a part of these conversations. So something that I think it's really important is just getting bedside nursing involved in these conversations and bringing up the topics and the issues that we see, you know, every day, and feeling empowered and feeling comfortable to be able to bring those to the table, and also being able to request an ethics consult on the types of patients that we really are concerned about and then we really have questions about, again, because we're the ones that are hands-on, we're the ones that are there for 12 hours a day, and ultimately all of these issues and concerns and things that we face every day lead to burnout and turnover and secondary trauma. So I think that just from the polls that I did, that those tend to be the three most pertinent topics right now for us.
Thank you, Courtney. All right, we're going to move over to Poh Pei Fen from Singapore.
Hi, thank you for having me. We do echo a lot of the things that has been said, especially the lack of professional development. Until today, we still don't know how is it going to be, because the truth is we don't have a pediatric intensive care nursing course. So like what LeBron said, we will go for the general pediatric master's degree, and the nurses are expected to come back to function at the APN. So we have one who has graduated, and currently she's just finding her way out. In terms of the burnout, I think COVID has showed us a different side of burnout. So the thing is, the unit is set up as a clean unit. We house the suspect or confirmed patients at another unit, but we share the same staffing. So these two nurses will be deployed to the other unit to nurse the suspect case first with their full PPE. So first, they are short of staff, and we have to keep in mind that these patients are full-fledged ICU patients. So we have resus cases, we have ECMO cases in that unit. So while they are short of staff, they are also relying on non-trained ICU nurses with that. So it was really very difficult, physically very tiring, because of the PPE, and the PAPR was really heavy, and also the lack of support. So we actually have nurses who resigned because of that. We realized that, so after we tried to speak to people, and of course we don't want them to resign at the peak of COVID, we realized that other than encouraging them to speak about it, having the managers supporting them, the technical support is important. Being fair, being treated fairly at work is also important. So what happened was we started rotating the nurses. So even though we were assigned to nurse COVID patient out of suspected patients out of the ICU, we felt it was quite fair because it was on rotation. So this experience actually does echo something that's very familiar, where we have difficult parents. When we sort of share the suffering, we think we sort of get over the frustration easier. Another thing about the COVID was that there was only one parent allowed. So I think being good nurses in other than helping at the bedside, we sort of adopt the parents. So we became part of their support. So it was a really very unique time then. So now we are back to the two visitors at the bedside. The last one is that the truth is, in my region, we are just starting and waking up to science and research. So we are actually very excited about the new knowledge that's coming out. We have many initiatives. Our nurses in the center take pride in the skin. So now we are very excited to use medical honey on wound, and we think that it's working out very well. We have been working with the sedation. We are doing very well with the rescue, sedative, and purges, and currently working on the weaning part, because the truth is the comfort of the nurses or the comfort of the patient, so that we are still working very hard on. And lastly, the family-centered care. So to let you know, in my region, we are pretty paternalistic, and you do as the nurse say. So we are starting to go towards finding out what the parents actually want and how we can facilitate that. So that's the 3 points from here.
Thank you. Manjinder, would you like to give us the perspective from India, please?
Thank you, Lauren. India is amongst the most populated country. Working in overcrowded, resource-deficient hospitals is a challenge in itself. We face multiple problems on 24/7 hours basis. The pediatric and neonatal critical care nursing is still in infancy stage. So the pertinent topics that I will be discussing may be the problems by nursing community in general. So basically the 3 problems that I am going to cover are staff shortage, then performing non-nursing jobs, and the lack of recognition. Staff shortage is a chronic problem in India. This parity nurse-patient ratio is on extreme levels. In a general pediatric unit, One nurse looks after around 20 patients, pediatric patients, and in neonatal emergencies, one nurse is assigned to look after around 30 to 40 sick neonates. And even in pediatric ICUs also, a single nurse is supposed to look after 2 to 3 critically sick patients requiring high dependency care. So many times these high patient ratios challenges our ability to take care and forces nurses to multitasking. And we encounter many adverse events related to medication errors, hospital acquired infections, needle stick injuries, compromised patient safety, and prolonged hospital stay. The increased workload due to staff shortage is a major factor which impacts the quality of work and many times challenges the intent to stay in nursing job. And migration is another factor that is contributing to staff shortage. Besides excessive workload to handle, nurses have meager salaries, especially in private sector hospitals. The private sector hospitals that forms around 70% of healthcare industry offer salaries as low as just $200 per month for a well-trained pediatric bedside nurse. So better salaries and standard of living in Western countries so tempting to avoid. So there is a passive acceptance of nurses migration on the part of Indian central or state governments. And one reason maybe the government want the people to migrate as they get foreign exchange. So no policy, guideline or legislation exists to check migration of nurses or other healthcare workers. So we are losing highly skilled and experienced nurses to Western world or Gulf countries. And the second topic that I am covering is non-performing non-nursing jobs. We perform an extensive variety of non-nursing jobs that range from maintaining the drug inventory, central sterile department supplies, then medical equipment logbooks, linen stock, admission and discharge registers, attending telephone calls, guidance and counseling of patients and their relatives, supervising student nurses, ward attendants, and sanitary attendants, and the list goes on and on. Performing these non-nursing jobs diminishes time for actual patient care, and sometimes at the end of the day, we astonish what nursing care actually provided throughout the day duty hours. So our most of our time is wasted performing non-nursing jobs only. Then lack of recognition. It is a fact that nurses are the linchpin in healthcare sector, and they are a critical link between patient and hospital. The present generation of nurses are aware of their rights and demand equality, but the due credit and recognition is denied. And no doubt, patient care is a team effort. We understand that. But being pediatric or critical nurses, their role is even more important. Many times, the only treatment needed to cure an illness in pediatric or neonate patient is meticulous nursing care. Though many pediatricians are aware of the vital role the nurses play, but very few acknowledge. And our healthcare systems are doctor dominated. When it comes to recognition, doctors get all the attention. The idea of team concept is followed more on papers, but in reality we still follow the same old traditional hierarchical system where nurses are considered as subordinates to doctors. Then the promotions in clinical nursing are seniority based, not performance based. Concept of lateral entries in nursing administration is missing. There is limited or no career progressions benefits for higher qualification. Demarcation in the role of highly qualified nurses in the hospital setting are missing. And so many times nurses do not find any motivating factor to perform better. And the concept of specialty nurses is almost imaginary. Nurses are rotated from one area of specialty to another without realizing what we are losing as a consequence. Their hard earned skills and knowledge is lost on the expense of gaining nothing. To add to their horror, they are expected to perform with the same acuity, passion, and commitment in each area of their next posting. And many times the nursing administration heads have no clinical experience of the specialty they are supposed to lead. No incentives for ICU or specialized care are provided. And the intellectual capabilities of nurses are rarely recognized, and they are pushed to a manual working class status only. So at some level, nurses feel cheated. Additionally, unsafe work environment, rigid working duty hours, meeting patient expectations are other issues that we face on daily basis. So that's what.
Thank you very much. That was great. Mathilde.
Hello, everyone. It's a pleasure for me to be here. And Manjinder, I think that you are incredible talking about your problems in India. In Latin America, we have almost the same problems. But as Livon said to us, we have 33 countries in Latin America. We have different nursing education. Nursing workforce is different, but one problem in Latin America is the staff mix that we have. So we have different nursing. So we have nurses with more than 5,000 hours of education, and we have assistants that have 500 hours of education. And we have these two professionals at the same ICU performing nursing care. So the society in Latin America, I think that it is 1,400 hours of nursing education is the median that we have. So we have a low social value due to different perspectives that the society has. The encounter that society has with nurses are different across Latin America. And for example, in Brazil, we have an impressive number of 2,400,000 nurses, nursing professionals, and only 24% are nurses, registered nurses. So we have few nurses performing nursing care, and this impacted in everything that all the colleagues said in excessive workload. We do not have healing environments, neither to patients or to nurses in PICU. So other problem that I can address is the high child mortality due to preventable causes that we have in Latin America. We have violence, we have malaria, we have other vector-borne disease that leading to death of children in the ICU. And we know that this is due to our economic and social inequalities. So this bringing a lot in a country like Brazil. We can have ICUs that I always say that can be compared with any ICU in US, Canada, UK, with one nurse to one patient and high tech at the bedside. And we have the majority of the society with a lack of mechanical ventilation, lack of supplies to for example, to suctioning. So basic medications. So we have this kind of inequalities that impacts in the results and in the social value. And so we have a shortage because few young people want to be a nurse because the value of in healthcare is central in physicians, in other healthcare professionals, even other in Brazil, have more social value than nurses. With the pandemic, I think that with some Marvel media, so we have some changes. People are, what is a nurse? Now they are understanding our role a little bit more with the media improvement of telling the importance of nurses to the society. So I think that what impacts in our 1 hour practice, what is different? I think that Minette will talk. When I have been in South Africa, I say we have the same problems. We change address, but the problems in nurses are the equal across the globe. Unfortunately, in some areas, due to inequalities and social problems, we have more acute and more suffering in nursing practice, maybe. But this is what I like to say to you. Yes.
Thank you, Mavilde. We are going to move on to Chris Ann.
So in Guyana, Marissa and I would both be sharing the 3 topics. So I would be looking at the lack of medical supplies and equipment, since this is a big issue affecting not only us at our hospital, but I can safely say it affects the entire of Guyana. It's quite difficult for us to turn theory into practice because the necessary requisites aren't always readily available. There's so much that we as nurses would like to do, but the limited resources makes it impossible for us to do so. The unavailability of basic medical supplies, we can all agree, should not be the reason for patients to receive suboptimal care. However, oftentimes we are faced with a situation where we have to decide which patient would probably benefit more from utilizing a piece of equipment or consumable because of the limited amount we have available. Other times we are forced to seek alternatives or improvise because the necessary medical devices or equipment cannot be sourced. This, the inadequacy of medical supplies extends even to the PPE. So during our training, most times we're taught that safety of ourselves should come first. However, the issue of inadequate and appropriate PPE have forever been an issue affecting our nurses and continue to affect us even today. I think the pandemic have worsened the situation too, because PPEs are now shifted mostly to the COVID hospital and the COVID units. So nurses are therefore placed in situations where they are at risk of harming themselves trying to save another life. And this in itself is quite distressing for our nurses. I'll now hand over to Marissa and she will discuss the other 2 topics.
Thank you, Chris Ann.
Hello, everyone. I think quite similar to what everyone has touched on already. Short staffing is one of the main topics impacting pediatric nursing in our country. Many of our nurses are migrating in search of greater job opportunities, better wages, and better work environment. Our current reality is that the nurses are leaving faster than they can be replaced, especially our registered nurses. And this leaves a serious strain on our healthcare system as the patient-to-nurse ratio increases. And this ultimately leads to like some of the things we talked about already, burnout, and further leads to other issues, including moral distress, medical errors, decreased productivity, and sadly, increased mortality rates. And just in the last month, we lost 4 registered nurses from our department who have migrated to the UK. So the remaining nurses that I have working are working additional hours just to cover the shifts. The other topic that I wish to talk on is the lack of training and education. Training and education is such an important role in promoting growth and practice and providing optimal care. At our training schools and even at our university level, there's limited emphasis placed on pediatric nursing as compared to adult nursing, which obviously impacts the quality of care given to our pediatric patients. Additionally, there's limited scope for advanced training. Apart from our NICU program, there are no other subspecialties in pediatric nursing here. Nurses working in our critical care unit are required to manage critically ill infants and children of all types of medical and surgical pathologies. And the only additional training they receive is facilitated by visiting teams from different countries, as there's no formal pediatric critical care program available here. And finally, another topic I wish to elaborate on is the psychological stress. Working in a critical care setting is a high stress environment, and that can prove both mentally and physically exhausting. And while the physical exhaustion may be a little bit easier to manage, the emotional and psychological impact may present a greater challenge. There are so many triggers to psychological stresses in the PICU NICU, such as the increased workload, the mental stress of just trying to complete every task, followed by the constant questioning of, did I do everything in the manner it was intended? Did I forget something, or could I have done better? The stress of having to work with limited supplies, especially during the pandemic, as my colleague Chris Ann just mentioned, and that feeling of inadequacy as it relates to assisting family with their emotional needs. How much information do I relate to them? What questions do I answer? How do I address their fears and concerns? And how do I help them cope with separation anxiety? And in closing, in my opinion, another great contributing factor to psychological stress is coping with death. It is so easy to get attached to pediatric patients, and it can be incredibly overwhelming to see a child suffer. And this makes it even more difficult for nurses to cope with the loss of a patient that they would have been, or they would have developed a close relationship with. So certainly, I think there's more need to provide nurses with an outlet and mechanisms to help them cope with the psychological stressors that we face in our work environment. Thank you.
Thank you both. Minette, we're going to move over to you. You have to unmute first.
Thanks very much, Lauren. And also for this invitation, I'm really glad to be standing in for Natasha North, who you met just last week. Mavelda, I was going to say that you reminded us of that 10 years ago. Globally, the problems they are similar, the address changes, but of course, along with the address, the geography changes. So there's so much that Musa and I've been thinking about, and in our review as just of a number of PICU nurses in different countries, that resonates with what's already been said. Africa, like the other continents, there are 55 countries in Africa, and so we really we're touching just on small portions of our sense. So I'm going to look at the first, I'm going to do shortly the first issue, and then Musa will pick up on the second two. This resonates definitely with what people have said. Our first issue, without a doubt, as we look at what are the three most pertinent topics that impact PICU in the region, would be the PICU nursing workforce. And of course, the issue that's completely linked with the PICU nursing workforce is training. So at this stage, we only have two, and I won't say we only have two centers that train PICU nurses, and I appreciate that some have none. So I'm saying this really with a new sense of, phew, we have two centers in the region that train PICU nurses. One is in Nairobi, Kenya, so that's East Africa, and the other is in Cape Town. And from our workforce data, we're really looking at 146 graduates from one, 56 in the other over 10 years. That's only 200. That's way too few for a continent in which the under 19 population comprises often 40 to 50% of most countries' populations. So with really low numbers of trained and experienced nurses means that the staff-patient ratios, and a number of us have spoken about that, are almost always insufficient. I put in almost just to make it feel better. They're always insufficient. Now and again, in some units, one might find a one-to-one, but that's rare. It really is rare. And particularly now, and we all know that small ratio of nurse-patient ratio really impacts PICU outcomes. And as more PICU services are being added into countries, a number of countries in our region have not had PICUs until some as recently as this year or last, and a number of countries do not have PICU, ICU, or even NICU units or centers at all. But as they get added to a large pediatric service, if you can't build that critical mass of nurses to enable the mentoring similar to Brazil, there are two groups of nurses. There are registered nurses and auxiliary nurses, and often auxiliary nurses, they work together, not with the same salary. Many of them are really experienced PICU nurses, but they're all in an age range of 55 to 60. That's a group of nurses we will be losing very soon. The younger ones, similarly to what Mavil just said, and in other countries, the social value of nursing has not been so high that nurses are doing nursing training in large numbers. So with that turnover that's really high, the more junior staff just can't be well trained. So just from this first point, moving back to training quickly, initiating in-country training programs to staff 6 or 10 bedded units in a country is very, very costly. I think, Fenella, you spoke about the costliness of implementing a program. So training in regional hubs in our context really does make sense. Between us, we're starting to tackle issues of student registration with particular nursing councils and PICU specialist nurse accreditation, and a very new group of APNs, 20 Africa-trained APNs across the entire continent. We're all at that point of beginning, it's new. And, but the workforce will remain a challenge as we go ahead. Over to Musa for the other two.
Thank you, Manette. Musa, are you ready for us?
Thank you, Chair. Thank you, Lauren, and thank you for this platform. And picking up on what Professor Minette Coetzee just said, the second point that is a challenge or an impact on the PICU NICU nursing is that managers or service administrators who are not clinically inclined or clinically educated insofar as critical care is concerned, they are managing from outside of the PICU NICU arena. Therefore, they are dictating what should be the practice, and therefore this leads to how resources are sometimes deployed. Sometimes because of that lack of clinical knowledge, resources are sometimes skewed in the wrong direction because these managers essentially are leading large hospitals or healthcare facilities. NICU or PICU nurse clinicians are not at the decision-making tables where they are able to make decisions regarding how critical care nursing should be carried out in their respective units, because they are not at the decision-making table, so where they'll be able to influence the direction of a PICU NICU nursing practice. There seems to be in our region a person-driven system dominance, which does not translate into positive outcomes in the PICU NICU practice. Instead of us having a process-driven system, which will translate into better guidelines for clinical care in the PICU NICU nursing. Because of this, managers or administrators are not clinically exposed to PICU NICU nursing. There's a lower organizational support for from these managers for the PICU NICU nursing, and this results in some tensions within these units. Then there's the wrong implementation or interpretation of guidelines because of these managers or administrators are managing from the outside. There is a top-down approach compared to a bottom-up approach, compared to where the bottom-up approach will work better because it will be initiated by the nurse clinicians in PICU NICU upwards, informing administrators that this is how we would like practice to be done. The third and the last point that we have as a challenge to the PICU NICU nursing in our region is the high burden of disease. So in our region, we have high burden of disease. Coupled with that, there's just a study that was released in 2019 that said that we have a limited amount of PICU beds for pediatrics. So in our region, having high burden of disease, 7.7 million people in South Africa are HIV positive, are on lifelong antiretroviral treatment. 47% of that are children. That just gives you the magnitude of the challenge on the PICU and NICU and nursing. The children we are admitting to our PICU and NICU are admitted with what will be straightforward diagnosis like pneumonia. But this pneumonia are complicated by the underlying HIV or nutritional deficiencies. Therefore, that places strain or extra strain on the PICU-NICU nurses. In a recent study that was published, it looked at the neonatal mortality. And they said nationally we are having a neonatal mortality of 27%. When they drill down on on classifications with what the cause, prematurity, birth asphyxia, and neonatal sepsis accounted for the top 3 of the causes of death. In a recent study in 2020 from a large regional hospital in Cape Town found that out of the population of pediatrics that they admitted in that pediatric ICU, 21.9% of them was as a result of severe sepsis, 61.6% were admitted with long-term complex chronic disorders. Now that in itself, in just one facility, is a concern, and that places a strain on the PICU nursing. And I will pause at that for now. Thank you.
Thank you. That was excellent, everyone. So we've come to the very last question. We have about 10 minutes left in our session. And our last question is first of all, I'd like to say that I've asked every member of the panel to post to all the attendees one word that they would use to describe the future of pediatric critical care nursing. And so for the attendees, that is what you've been starting to see. And so then that's why you're starting to see those singular words. So Mavilde, we'll start with you. What does the future of PICU nursing look like?
Yes, it's a very nice question. I would like to address healing environments to patients and for professionals also. 5 years ago, we changed our discipline on patient safety to healthcare safety. And the pandemic showed us that we have to have safety to all of us, not only patients, but healthcare providers also. So healing environments to children and families, I'm talking about smell, noises, the experience to be in the ICU, because we have each time more different patients in our units. And also in the future, for sure, a future that we have 1 for 1, 1 for 2 nurses for patients, and that nurses say, not only that I love nursing, because we listen is, I love nursing, but I hate my job. So we want to hear that I love nursing and I love my job in the future also. And for sure, I think that information technology will change our lives in the ICU in the near future when we are talking about the way we practice. So I will pass to you to give some moments to questions, okay?
Thanks, Mavilde. So I'm going to do a little bit of summary and a little bit of conversation about the future. I think one of the most poignant points was made by Mavilde and Manette talking about same things, different address. So when I look at these questions from the perspective of someone living and working in a high income country, I wonder about how this all impacts us. And within the area that I work, we see the devastation of social determinants of health and the impact of high income families who have every resource in the world, oftentimes right next to each other. We know in the city of Chicago, the further north you live, the longer you live. So as you move further south in Chicago, your life expectancy decreases by 10 years. And this literally is just one city. So we know that this plays out in all areas of the world. The issues of stress, burnout, social determinants of health, staffing, education, lack of specialty training affect many of us around the world. And even though we can't account for every part of the world that is represented here on this panel, we know that from this conversation, the issues are the same. There's a brotherhood or sisterhood or personhood of the experience of us all having similar issues, just playing out a little bit differently in our geography. So in some ways, there's some comfort in knowing that. And in other ways, there's some sadness that comes that we're all experiencing the same problems and yet seem to be in a spot where we're challenged to manage those issues and make them better. So because of that, what do I think the future of nursing looks like for us? Well, I know that the WHO with the International Council of Nurses and Nursing Now set forth the 2030 goals published in the Year of the Nurse. As everyone knows, this is the Year of the Nurse and Midwife. And they actually say that there is not a nursing shortage now, but there will be one by 2030. Many, many millions of nurses in shortage. Interestingly, they identify some of these exact same issues: education for nurses, the migration issues that are significantly challenging, particularly to low-income countries, though believe it or not, is also an issue in a high-income country where nurses leave one area of the country to go work in another area to make more money. So it's not a unique experience just to low-income countries. It just works out a little bit differently. So when I think about where we are moving into the future, I see that this group here is a beginning collaboration to making change in the future. We have the opportunity and potentially, one might say, the responsibility to advance our profession forward. And as Lavon asked in the chat about WFPICCS having a responsibility in this, of course, WFPICCS also does. As one of our core missions of education, it's about education for the whole team, not just education for physicians or trainees or specialists, but rather all members contributing to the team. So as one voice for nursing, WFPICCS can certainly provide a platform for ongoing education for nurses, and that work is yet to be done. So I think that our future, my one word for our future is that our future is bright. We have an opportunity to make change. And I will say that I've been accused of being an optimist in the past, and that's just fine with me, because I think that although there's work to do that feels like it could be overwhelming at times, we have the opportunity to make a small contribution, no matter how big or how small, to continue to move the message forward and advance our profession. So other words, just in case the team has not seen them, those attending, we have hopeful, and we have collaboration, optimistic, we have unpredictable. Indeed, it's unpredictable. We will be dealing with many unpredictable things in the future. Promising, challenge, networking, and a long way to go. So if anyone would like to make any other final comments, we have about a minute or two until I close this completely.
I'm just wondering whether, WFPICCS should do like a white paper or have like a position statement on what came out of these two sessions, just to give, some political and leadership power to those regions where that need, support. And
yes.
Because, it's quite powerful to have, a worldwide organization that encompasses, so many federations to convince decision makers and to try to lobby at local level.
Yes, I actually think that is an excellent point to be made, and I think that we can move that forward. So I would invite you all to be available to do that. Everyone has had major contributions to this conversation, both in the last session and in this session. and it would be an excellent outcome to produce a paper with our discussion from both, and a highlight and a testament to the Year of the Nurse. With that, I'm going to close with 2 Florence Nightingale quotes. I couldn't pick just one this time like I did last time. Everyone, I think, is well aware of this quote. And what nursing has to do in either case is to put the patient in the best condition for nature to act upon him. And my closing quote for today from Florence Nightingale in celebrating our final session and the Year of the Nurse and Midwife is, rather 10 times die in the surf, heralding the way to a new world, than stand idly on the shore. I think that reflects all of us today. So thank you all for joining. The session has been recorded and it will be posted on our website, and we will be in touch to get moving on our publication. Thank you all and happy holidays.
Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you. Thank you.
Thank you.
Thank you all. Goodbye. Thanks,
Thank you. Bye.
Lauren.
Thank you,
Bye.
Manette, and everyone for participating.
Thanks.
This was
Yeah,
excellent.
thank you for putting this together.
Yes.
Bye.
Thank
Yeah,
you. Such
thank
an
you,
honor to
Lauren.
be here. Thanks, Lauren.
See you later.
Bye. See you.